Morning, and delighted to be here in this energetic morning. Many thanks to the organizing committee for having me again in another special wave of Diabetes and Ramadan conference. I'm delighted to be here among the people here in presence and as a big gathering in the platforms of the virtual platforms. I've been given the task to cover the oral hypoglycemic agents modification during Ramadan fasting. This is my disclosures. And the main resources of recommendations that I will be using during my talk is the Diabetes and Ramadan Guidelines 2017 version and the IDF Diabetes IDF DAR Guidelines 2021 version, and the suggested newer guidelines, which is a collaboration between ADA, IDF, and DAR that will be expected to be published in the coming few weeks. As you all know, the main risks of fasting in people with diabetes during Ramadan includes the hypovolemia, hypoglycemia, hyperglycemia, decline in renal function, query-ketonemia, and hospitalization with any diabetes-related complications. And most of us are practicing healthcare providers, and we know that the common hypoglycemic agents that's being used currently are a couple of oral hypoglycemic agents, including metformin, SGLT2 inhibitors, TZDs, sulfonylureas, DPP4 inhibitors, acarbose, and the injectable forms of GLP and insulin. I'll cover the oral forms, and I leave the bumpy road, as I mentioned a while ago, to my friends and colleagues, Professor Khadija and Professor Wasim. In a short note, that all the previous guidelines have concurred that those groups of medications are safe, good to go during Ramadan fasting, and no need for dose adjustment. Metformin, TZDs, and acarbose. So I won't delve deeper into the evidence beyond that, and this has been consistently recommended in all previous guidelines. So it can be rearranged. For example, if the patient is on 3 times metformin, it's not commonly being practiced now, then 2 tablets can come in the breaking the fast time, and 1 tablet to go to the sahur time. So it's sort of rearrangement, but no dose adjustment is needed for those groups of medications. What about DPP4 inhibitors? In fact, the science on DPP4 inhibitors in Ramadan goes back to almost 18 to 20 years back. So we have a very solid background, solid evidence that they are safe during Ramadan, and we have multiple systematic reviews and meta-analysis. And this one have compared DPP4 inhibitors with various other agents of anti-diabetic medications, including metformin, sulfonylurea, pioglitazone, and GLP receptor agonist. And out of all those studies, DPP4 inhibitors have shown a very reasonable and reassuring low risk of hypoglycemia, except in 3 trials or studies. One compared to metformin is slightly higher, 1 case out of 304 participants, while in the metformin arm it was 0 out of 158. So 1 case of documented hypoglycemia, and slightly higher when it was compared to TZDs, and 1 study compared to GLP receptor agonist. So the overall, the evidence behind the safety of DPP4 inhibitors in Ramadan were quite robust, and that led the guidelines to consistently say DPP4 inhibitors are safe during Ramadan fasting, no need for dose adjustment, just take them at iftar time whenever possible. So again, good to go with the DPP4 inhibitors. What about sulfonylureas? Again, we can take the same slide, but instead of left to right, right to left this time. So comparing sulfonylureas with the DPP4 inhibitors, way higher risk of having hypoglycemia compared to DPP4 inhibitors. In some studies, more than 88% higher risk of hypoglycemia. But as you can see, the references, it goes back probably 10, 15 years ago, where the older generations of sulfonylureas were used, and probably with the newer one, things have changed, and that was the case. So this is another study conducted by Professor Hassanin and multiple colleagues from across Middle East and North Africa region, and they compared people on oral anti-diabetic medications without sulfonylurea to people on oral anti-diabetic medications including sulfonylurea, or people on insulin-based therapy. And the risk of hypoglycemia increased by double by just having sulfonylurea on board, and increased by another double when they having insulin on board. Comparing the oral anti-diabetic medications with no sulfonylurea with the insulin group, the risk increased by 4-fold. So the jeopardy will basically be on the insulin therapy on the background, plus or minus sulfonylurea. But not all the sulfonylureas are the same, and this study has been conducted across the Far East Asia, from India and other Asian countries. They compared various types of sulfonylureas, and please focus only on the light blue bar where the glycoside was concerned in this analysis. So the risk of hypoglycemia went between 1.6 to 2.4, 2.8%. So this, in simple math, this could be one time per or 1 day out of the 30 days of Ramadan. So the glycoside per se, the newer generation of sulfonylurea, carried a very low risk of hypoglycemia compared to other older generations of sulfonylurea. And this has also been compared in multiple studies where the glycoside has been compared to DPP-4 inhibitors, and we've mentioned that it carries very low risk of hypoglycemia, and it was comparable in 2 studies, and is even less hypoglycemic events compared to DPP-4 inhibitors in another study. So this made us to dissect the sulfonylureas into older generation and the newer generation. And here I will not go to the previous recommendations, just for the sake of simplification. So we divided the sulfonylureas in the upcoming recommendation into modern sulfonylureas, including glycoside and glimepiride, and versus older sulfonylureas, which is glibenclamide and glipizide. And the recommendation now, the recommendation that we are proposing, and it will be published soon, that if the patient is on the modern forms of sulfonylureas on once daily dose, carry on with the same dose. But if the blood glucose and glycemic indices are very well controlled, then consider minimizing the dose. If the patient is already on twice daily modern sulfonylurea, keep the morning dose the same at iftar time, but half the second dose to be taken at sahur time. If the patient is already on older sulfonylureas, the first recommendation is, whenever possible, switch to the newer forms that carries much lesser hypoglycemic risk. And if the patient is whether on once daily or twice daily, then half the dose, whether it's once per day at iftar time or half the dose twice a day at iftar and at sahur time. Okay, what about the SGLT2 inhibitors? And this is one of the most dynamic parts of the Diabetes and Ramadan guidelines. We tried to gather everything in a nutshell, and we presented this systematic review we just published a couple of months ago, where we analyzed the 12 published studies on safety of SGLT2 inhibitors during Ramadan. At that point in time, there were 12, now there are more. And as you can see, the SGLT2 inhibitors forms are decently represented: empagliflozin, canagliflozin, and dapagliflozin as the time of the publication of this document. And only one study out of all have documented high risk of dehydration or hypovolemia. And it's important to say that even this study, they documented the symptomatic hypovolemia. There was no substantial sort of monitoring for that. And only 2 studies have shown the lower eGFR by the end of Ramadan, both of them from Pakistan. And interestingly, the one from Aisha and her group, the creatinine almost remained the same, 0.97 to 0.94 by the end of Ramadan. But the eGFR was statistically lower before and after Ramadan. And another study also from Pakistan have shown a remarkable or statistically significant reduction in eGFR after Ramadan. And the new kid in the plot is that even ertugriflozin has been assessed as safety of Ramadan, and they concluded that the ertugriflozin is safe to be used during Ramadan with no major jeopardy. And we decided to sell even further than just checking the safety of SGLT2 inhibitors in people with diabetes, and we assessed the safety of SGLT2 inhibitors in people at high risk of fasting based on the previous calculator, and those defined as people on insulin, type 2 diabetes on insulin, CKD stage 3, or stable coronary artery disease. And the brown part of the table is the SGLT2 group, which was 36 patients, compared to non-SGLT2 groups with around 50 individuals. And we monitored them using the flash glucose monitoring across the month of Ramadan. There was no difference in terms of systolic blood pressure, diastolic blood pressure, or creatinine before and after Ramadan in both groups, whether on background of SGLT2 or not. And the glycemic control was a bit better in the SGLT2 group. Comparing SGLT2 inhibitors group versus non-SGLT2 inhibitors group, there was a bit better glycemic indices in the analysis of the Libre sensor of flash glucose monitoring. However, there was no signals as hypoglycemia episodes number, severity, and duration. So having SGLT2 inhibitors at a high risk of fasting Ramadan did not jeopardize the fasting outcomes. So this made the guidelines a little bit dynamic, as I've mentioned. In 2017, the recommendation was do not initiate SGLT2 within 2 to 4 weeks before Ramadan. If closer, use the much lower dose, increase fluid intake, no dose adjustment is needed if the patient is already on SGLT2 inhibitors, and avoid using SGLT2 during Ramadan in elderly, diuretics, and hypotension. 2021, we crossed this, if closer, use lower dose, because there is no evidence of benefit of the lower doses of the half dose 5 milligrams of, for example, of double deflozin, but still the recommendation initiated 2 to 4 weeks before Ramadan. Now, what we are suggesting, based on the plenty of evidence of safety that we have, we can initiate the SGLT2 inhibitors up to Ramadan. So just before Ramadan, we can initiate the SGLT2 inhibitors, provided that we provide a decent education, increase fluid intake during the fed hours, and no dose adjustment is needed, and exercise caution, not avoid. Caution in elderly, and if the patient is on diuretics in the background. And this strong recommendation has come from the dynamic move. 2017 guidelines, we had only one study, and it was survey from experts in the field. Now we're having 15 dedicated safety data or studies on SGLT2 inhibitors in Ramadan. So this made the recommendation is more informed. And just in addition to that, we have even mentioned that if deemed necessary for cardiorenal protection, SGLT2 inhibitors may be initiated with caution during Ramadan, provided that the patient is thoroughly informed about the potential risk and advised on all necessary measures to prevent dehydration. And we have even evidence for that. This study have examined people initiated on SGLT2 inhibitors during the month of Ramadan, and again, the conclusion was quite reassuring. So multiple oral hypoglycemic agents, nothing much to say. It's defined as 3 or more antidiabetic medications. Now the education becomes a necessity, not a luxury. Those individuals has to be well educated. Dose adjustment is needed, and we recommend CGMS whenever possible. So with that, Mr. Chairman, dear colleagues and friends, please allow me to conclude that with the same graphs, metformin, TZDs, acarbose, no risk of hypoglycemia during Ramadan, carry on with the same dose, no dose adjustment. And for DPP-4 inhibitors, again, same dose, take it at iftar. Sulfonylureas, dissect them, older generation, newer generation. If the older one, try to switch to the newer ones as much as possible. SGLT2s we are having larger or wider range of safety now, and we can initiate it up to Ramadan and with appropriate education. And with that, I'd like to thank you very much and happy to answer any question.